بسم الله الرحمن الرحيم. معاكم أستاذ دكتور طارق امين الشاذلي، أستاذ الباطنة والجهاز الهضمي والكبد، كلية الطب جامعة المنصورة. موضوعنا النهاردة عن lower GI bleeding. This picture shows the blood supply of the colon and the small intestine. The superior mesenteric artery supplying the small bowel and the right side of the colon, and the inferior mesenteric artery supplying the left side of the colon. The superior mesenteric vein drain the right side and the small intestine, joining the splenic vein forming the portal vein, and the inferior mesenteric vein drain into the inferior vena cava. Lower GI bleeding is bleeding from the distal to the ligament of threads. Colonic cause represent about 95%, small intestinal cause about 5%. Patient can be presented by hematochezia, melena, hematemesis, or occult blood. Etiology. This diagram shows different causes of lower GI bleeding from below upward. The anorectal cause like hemorrhoid, anal fissure, or salivary rectal ulcer. Colitis like Crohn's disease, ulcerative colitis, usually associated with diarrhea. Polyp, carcinoma of the left side, ischemic colitis, angiodysplasia, diverticular disease, carcinoma of the cecum, and Meckel's diverticulum. Anorectal causes like fissure, piles, or salivary ulcer. Inflammatory like bacterial dysentery, parasitic dysentery like bilharzia, or viral infection. Tumor like polyp, cancer of the right side of the colon, cancer of the left side of the colon. Vascular like angiodysplasia or ischemic colitis. Autoimmune or idiopathic cause like inflammatory bowel disease, ulcerative colitis or Crohn's disease. Diverticular disease, radiation colitis, and bleeding tendency. Small intestinal causes like angiodysplasia, GIST, gastrointestinal stromal tumor, polyp, peptic ulcer, typhoid ulcer, hemophilia, and bleeding tendency. Hemorrhoidal and anal fissure. Bleeding is typically small volume, intermittent, and bright red on the surface of the stool. Occasionally bleeding is severe. The diagnosis can be confirmed by endoscopy and or flexible sigmoidoscopy. Severe or recurrent bleeding are indication for a hemorrhoidal band ligation or hemorrhoidectomy. Anal fissure may also cause bleeding that is usually minimal and is associated with anal pain or discomfort. Fiber supplementation and laxative are advised. This is a picture of internal piles. Colonic diverticula. Local erosion into one of the arteries lead to brisk but usually self-limiting bleeding. Rarely bleeding is massive on presentation. Recurrence in about 25% after the initial episode and increasing up to more than 50% in the second or third episode. Requiring emergent diagnostic colonoscopy, angiography, or surgical management. The picture of diverticular disease. Angiodysplasia are common cause of bleeding from the small bowel and the colon. Vascular ectasia occur throughout the upper and lower intestinal tract and cause painless bleeding ranging from melena, hematochezia to occult bleeding. Colorectal neoplasm, benign polyps, and carcinoma are associated with chronic occult blood loss or intermittent anorectal hematochezia. However, chronic neoplasm may cause up to 10% of acute lower GI bleeding, although colorectal cancer is most commonly associated with occult blood loss rather than overt bleeding. Patient with rectosigmoidal lesion may present with hematochezia. The diagnosis is rarely made on endoscopy. The picture of colonic polyp and another picture of colonic carcinoma. Infection, inflammatory or ischemic colitis. A variety of infection, inflammatory and ischemia may present with bloody diarrhea. The diagnosis of infectious colitis is usually confirmed by stool culture or assay of Clostridium difficile toxin, but occasionally stool studies are negative. Endoscopy is always indicated in the setting of possible inflammatory or ischemic colitis.